Dear students, Assalamu alaikum. Towards the later part of last lecture, we studied the steps involved in causing hyperosmotic renal medullary interstitium. The objectives of today's lecture are to learn about rest of these steps involved in the formation of concentrated urine and osmolar and free water clearances. So we continue with the topic of formation of concentrated urine. Let's now study the role of distal tubule and collecting ducts in excreting concentrated urine. The fluid in the distal convoluted tubule in renal cortex is dilute, that is 100 milliosmoles per liter. The early distal tubule further dilutes the fluid. In cortical collecting tubule, water reabsorption is dependent on antidiuretic hormone. In the absence of antidiuretic hormone, this segment is impermeable to water but continues to reabsorb solutes and further dilutes the urine. When antidiuretic hormone level is high, cortical collecting tubule becomes permeable to water. Large amounts of water are reabsorbed into the cortical interstitium, where it is flown away by the peritubular capillaries. The fact that large amounts are reabsorbed into the cortex rather than into the renal medulla helps to preserve the high medullary interstitial fluid osmolarity. During high ADH levels, collecting ducts become water permeable. So, the fluid at the end of the collecting ducts has the same osmolarity as the interstitial fluid of the renal medulla, that is 1200 milliosmoles per liter. This figure shows formation of a concentrated urine when antidiuretic hormone levels are high. Note that the fluid leaving the loop of Henle is dilute but becomes concentrated as water is absorbed from the distal tubules. With high ADH levels, the osmolarity of the urine is about the same as the osmolarity of the renal medullary interstitial fluid in the papilla, that is equal to 1200 milliosmoles per liter. Contribution of urea to hyperosmotic medullary interstitium. So far, we have considered only the contribution of sodium chloride in the creation of a hyperosmotic renal medullary interstitium. However, urea contributes about 50% of osmolarity, that is 600 milliosmoles per liter of renal medullary interstitium when the kidney is forming a maximally concentrated urine. Urea is passively reabsorbed from the inner medullary ducts into the interstitium. Mechanism of reabsorption urea. Little urea is reabsorbed from the ascending loop of Henle, distal and cortical collecting tubules, because these segments are impermeable to urea. Urea concentration increases in cortical collecting tubule when high antidiuretic hormone causes water reabsorption from the cortical collecting tubule, as urea is not very permeant in this part of the tubule. In inner medullary collecting ducts, water reabsorption causes even higher concentrations of urea. Urea diffuses out of inner medullary collecting ducts by urea transporters, urea transporter A1 and urea transporter A3. Urea transporters are activated by antidiuretic hormone. Now let's study concentrations of urea in different parts of tubule. In proximal convoluted tubule, 40 to 50% of filtered urea is reabsorbed, and even so urea concentration increases because urea is not as permeant as water in this segment. In the thin segment of loop of Henle, the concentration of urea continues to rise because of number one, water reabsorption out of the descending loop of Henle. And the concentration of urea continues to rise because of number two, secretion of urea into the thin loop of Henle from the medullary interstitium. This is facilitated by a different type of urea transporter A2. This figure shows recirculation of urea absorbed from the medullary collecting duct into the interstitial fluid. This urea diffuses into the thin loop of Henle and then passes through the distal tubules, and it finally passes back into the collecting duct. The recirculation of urea helps to trap urea in the renal medulla and therefore contributes to the hyperosmolarity of the renal medulla. The heavy lines from the thick ascending loop of Henle to the medullary collecting ducts indicate that these segments are not very permeable to urea. Urea transporters UTA1 and UTA3 facilitate diffusion of urea out of the medullary collecting ducts, while urea transporter A2 facilitates urea diffusion into the thin descending loop of Henle. We come back to the concentrations of urea in different segments. The thick limb of the loop of Henle, distal tubule and cortical collecting tubule are all impermeable to urea. Little urea reabsorption occurs in these tubular segments. The concentration of urea in the cortical collecting tubule rises further when high levels of ADH are present, causing reabsorption of water from the distal tubule and cortical collecting tubule. In the inner medullary collecting duct, high urea concentration and the urea transporters A1 and A3 cause urea to diffuse into the medullary interstitium. Recirculation of urea. Urea can recirculate through the terminal parts of the tubular system many times before it is excreted, as shown in the following flow chart. Increased urea in inner medullary collecting duct causes urea diffusion by urea transporters into the medullary interstitium, from where it is diffused to thin segment of the loop of Henle. From there it passes upward to ascending limb of the loop of Henle, distal tubule and cortical collecting duct, and then it is increased again in the inner medullary collecting duct. So in this way This urea recirculation provides an additional mechanism for forming a hyperosmotic renal medulla. Preservation of hyperosmolarity of renal medulla is important and requires a special medullary blood flow system. Otherwise, the solutes pumped into the renal medulla by the countercurrent multiplier system would be rapidly diminished. So let's talk about the preservation of hyperosmolarity of renal medulla. There are two special features of renal medullary blood flow that contribute to the preservation of high solute concentrations in the renal medulla. First feature is low medullary blood flow. This helps to minimize solute loss from the medullary interstitium and is sufficient to supply the metabolic needs of the tissues. Second feature is that the vasa recta serve as countercurrent exchanges, minimizing washout of solutes from the medullary interstitium. So now let's study about this countercurrent exchange mechanism, that how it minimizes the washout of solutes from the medullary interstitium. Blood enters and leaves medulla by vasa recta, which are highly permeable to solutes in the blood except plasma proteins. Blood flowing down the descending vasa recta becomes progressively more concentrated because of solute entry from the medullary interstitium and loss of water into the medullary interstitium. As blood ascends back in the vasa recta towards cortex, it becomes progressively less concentrated because now the opposite events occur, that the solutes diffuse back into the medullary interstitium and water diffuses back into the vasa recta. this figure shows the counter current exchange in the vasa recta. Plasma flowing down the descending limb of vasa recta becomes more hyperosmotic because of diffusion of water out of the blood and diffusion of solutes from the renal interstitial fluid into the blood of vasa recta. In the ascending limb of the vasa recta, opposite occurs. The solutes diffuse back into the interstitial fluid and water diffuses back into the vasa recta. Now, it is important to realize that large amounts of solutes would be lost from the renal medulla without the U shape of the vasa recta capillaries. So that is a special feature of the vasa recta capillaries, as we have studied in the anatomy of the renal tubular system. So there's little net dilution of concentration of interstitial fluid at each level of the renal medulla because of the U shape of the vasa recta capillaries, which act as counter current exchanges, as we just studied. The vasa recta carry away only as much solute and water as is absorbed from the medullary tubules. In this way, the high concentration of the solutes established by the counter current mechanism is preserved. So this is the end of the topic of the formation of concentrated urine. We continue with the next topic, which is quantification of the renal urine osmolarity. The process of concentrating or diluting the urine requires the kidneys to excrete water and solutes independently. So this is very important to understand, that the kidneys excrete water and solutes absolutely independently, not dependent on each other. So therefore, it means when the urine is dilute, that means water is being excreted in excess of solute. And when the urine is concentrated, that means solutes are being excreted in excess of water. Simply meaning more solutes are being excreted and less water is being excreted. So let's now study about the osmolar clearance. The total clearance of solutes from the blood can be expressed as the osmolar clearance, COSM. This is the volume of plasma cleared of solutes each minute. Osmolar clearance is calculated as COSM equal to UOSM into V divided by POSM, where UOSM is the urine osmolarity, V is the urine flow rate, and POSM is the plasma osmolarity. Free water clearance. Free water clearance is a concept by which the relative rates at which solutes and water are excreted can be assessed. The relative rates of solute and water excretion. So, free water clearance, denoted as CH2O, is the difference between water excretion, that is the urine flow rate, and osmolar clearance. So therefore it is calculated as CH2O is equal to V minus COSM, where putting the value of COSM, we get V minus UOSM into V divided by POSM. The rate of free water clearance represents the rate at which solute water, free water, is excreted by the kidney. So this is another angle of looking at the excretions of solutes and the water. So we can say that the free water clearance is positive when excess water is being excreted by the kidneys. And the free water clearance is negative when excess solutes are being excreted by the kidneys and water is being conserved. Free water clearance may also be expressed in terms of concentrated and dilute urine. For example, in concentrated urine, urine osmolarity is greater than plasma osmolarity, and free water clearance is negative, indicating water conservation. And in dilute urine, urine osmolarity is less than plasma osmolarity, and free water clearance is positive, indicating the water is being removed. This is the end of today's lecture, and we'll continue with the next topic in the next lecture.